Hey everyone, welcome back to GME Compass. I'm Julie Gualano. Today, we're tackling a common question that I hear from program directors, coordinators, and managers and other GME professionals. Who should actually be on your clinical competency committee? How often should the committee meet? While ACGME requires every program to have a CCC, many programs still tend to struggle with their committee structure, membership selection, meeting frequency, and their overall effectiveness. Some committees are too large, some too small, some meet too often, some not nearly enough. Many programs build committees based on tradition as opposed to intentional design. Today's discussion is going to help you to evaluate whether your current CCC structure is truly supporting meaningful learner assessment and development. So let's get started. Before we begin, a few disclosures. I have no financial disclosures related to this presentation. The information that's shared today comes from the broad continuum of experiences that have shaped my career in graduate medical education of nearly 2 decades. The content reflects my personal knowledge, observation, and experience. It's not intended to represent any GME role or organization. As always, I encourage viewers to review the most current ACGME common program requirements as well as the specialty specific requirements applicable to their program. Especially if you're watching this video at a future point in time, you want to make sure that there aren't any changes, additions, or updates to your program requirements when implementing information from this video into your program. By the end of today's session, you should be able to understand ACGME CCC membership requirements, identify characteristics of effective committee members, recognize common membership mistakes, determine appropriate meeting frequency, identify strategies that support effective committee operations, evaluate whether your current CCC structure is meeting your program's needs, evaluate whether your current CCC structure is meeting your program's needs. The goal is to move beyond simply checking a compliance box and instead focus on building CCCs that truly support learner and trainee development. So let's start our conversation with an important question. Why does the CCC structure even matter? This is a very simple answer. The Clinical Competency Committee is intended to influence nearly every major learner assessment decision within your program. Its impact is resident and fellow development, milestone reporting, early identification of a struggling learner, graduation readiness and preparedness, program improvement efforts, and accreditation compliance. So when committees are structured effectively, they create consistency, fairness, as well as credibility. When they're structured poorly, you can introduce bias, inconsistency, missed opportunities to support your learners. The quality of your CCC decisions will only ever be as strong as the people and the processes that are behind them. A misconception surrounding CCC is that ACGME provides detailed instructions regarding membership and meeting schedules. The truth of it is, the requirements are actually fairly broad. ACGME requires a CCC, at least 3 committee members, faculty appointed by the program director, review of resident or fellow performance, recommendations regarding milestones. Truthfully, that's really the foundation of it. What ACGME does not require is equally important. They don't require specific specialties on the committee, specific titles of faculty, fixed meeting frequency, or a large committee. That flexibility means programs have significant freedom to design a CCC that works for their unique environment. For many years, I felt like I was a proponent of, I wish the CCC would better define or would more specifically define what equals a quorum, or exactly how often you should meet, or the right cadence of when you should meet, or insert whatever detail you want. And as I became chair of ATMOG and I started to meet more frequently directly with the ACGME and have conversations with them and ask questions and really have a seat at that table, I started to hear and eventually understand. It took some time for me to understand, but that ACGME is very intentionally vague. And they're intentionally vague because they're trying to set all programs up to be successful whenever they can. And that is any program dependent on what their resources are, what their size is, what their institutional setup is, they try to make it in a way that this skeleton of the infrastructure requirements can be achievable and attainable regardless of the program. This is a favorite slide of mine because it addresses another misconception that many programs believe that they need representation from every rotation, every service, every clinical area. As someone who came from a community program, that's not practical. That's never going to happen. Not to mention, depending on how many services, clinical areas, rotations you have, that's a lot of noise and a lot of voices in the room. And that makes it really, really hard to drill down to the core of the discussion that you need to have for each individual trainee. So you can hear things like, we need someone from every rotation. That's not necessarily the right question. Instead, you want to think about who can provide meaningful assessment of learner performance. The focus should more be on quality observations, the ability to interpret assessment data, educational perspective and experience, and commitment to learner development. That's really important. A CCC is not intended to be a representative council. It's intended to be an assessment committee. That distinction is very important. So, who should be on the committee? Most successful CCCs include a program director, depending on your specialty requirements, your associate program directors, core faculty, faculty that might be actively involved in resident education, and faculty that is familiar with milestones. A useful question to ask is, who regularly observes our learners? Those individuals often bring the most meaningful insights. Sometimes the most valuable CCC member isn't the department chair. It's the faculty members who work closely with your residents or your fellows every week and can provide thoughtful observations. So let's talk about qualities rather than titles. Effective CCC members are objective, they're fair, they're consistent, they're engaged in resident education. They're open to discussion, comfortable reviewing data, they're committed to learner development, and they're willing to challenge assumptions. I'm also going to go one step further and say they also recognize the importance of psychological safety and confidentiality within the CCC environment. Notice that experience alone is not a defining characteristic. Engagement matters far more. A highly engaged educator can contribute more than someone with an impressive title who rarely participates. That's a stereotype and a thought process that is really hard to get beyond in graduate medical education. However, it is really important that your engaged educators have seats at a table, regardless of their title or who they are. To complement exactly what I was just saying, strong committees benefit from diversity of perspectives. That doesn't necessarily mean demographic diversity. However, that is absolutely valuable and something that should be kept in mind when creating your clinical competency committee. It also means diversity of educational and clinical experiences. Consider including faculty who bring different clinical backgrounds. The majority of my history and experience is from OBGYN. We had a massive MFM department, and that MFM department had more admin time than our generalist faculty. However, we couldn't have committees only of our MFMs. We needed to make sure that there was balance between OB and GYN, MFMs, and other subspecialists, in general, subspecialists and generalists. Various practice settings, different educational perspectives, longitudinal learner exposure, different teaching environments. Why? Because multiple perspectives reduces the bias, it improves decision quality. When everyone thinks exactly the same way, that's when you create blind spots. Thoughtful diversity strengthens assessment. An extremely debated CCC question is, should the program director participate? The honest answer is, there's no universal answer. Potential advantages include direct understanding of the learner performance, improved continuity, faster follow-up actions. However, there are barriers and challenges. Your program director can influence the committee discussion. They can reduce open debate and conversation. They can create perceptions of bias. The best approach is to review specialty-specific requirements and consider your local program and institutional culture. Some programs function extremely well with the PD participating. Others intentionally separate the PD from the committee deliberations. Both models can be successful. It's really about thinking about the culture within your larger institution and your program in and of itself. Here's another common question. If you saw my Understanding the ACGME CCC Requirements video already, you know where my loyalty, my opinion stands on this question. But across GME, you're going to see different models. Should program coordinators attend the CCC? In many programs, coordinators attend and support things such as the logistics, the documentation, the action tracking, and the data collection. Other programs maintain faculty-only discussions and complete documentation afterwards. Going by ACGME rules and recommendations, neither approach is inherently right or wrong. The key principle is support the process while maintaining confidentiality and professionalism. Many coordinators provide tremendous value because they help to ensure consistency, organization, and follow through. My bias answer is absolutely the program coordinator should attend the CCC. You have knowledge and understanding across the continuum of your learner's big picture academic profile that is unlike any other. You also have a process, policy, and procedure, institutional knowledge and memory that is also unlike no other. Bringing those two worlds together, having that multi-systems expertise and being the operations expert in your program, as well as being the central hub of the wheel, is invaluable. That is my personal opinion. I feel like it is not more important for the program coordinator, manager, GME professional to be there than the program director. I feel like personally, it is equally important. So can non-physicians serve on the CCC? The answer often is yes. But as always, you want to make sure that you double check your specialty specific requirements. Potential contributors could include psychologists, pharmacists, advanced practice clinicians, educators, or other healthcare professionals. Again, ask the same question. At the end of the day, what is the most important is, do they contribute meaningful assessment information? If they provide valuable perspectives regarding learner performance, they may strengthen committee discussions. Assessment quality should drive membership decisions. ACGME requires at least 3 members. However, what works best in practice? Many successful programs find a sweet spot of about 5 to 9 active members. Why? If the committee is too small, perspectives become limited. Bias risk tends to increase. If the committee is too large, I had mentioned this earlier, scheduling can be extremely difficult. Discussions can become less efficient. It is so much more easier to go down a rabbit hole and lose the focus and intention of the meeting, and participation also decreases. 5 to 9 members often provides enough diversity while maintaining meaningful discussion. So let's talk about some mistakes that I frequently tend to see. You want to avoid things such as selecting members solely based on their title. That is the first one for a reason. That is probably one of the biggest mistakes that I see. And then very close behind is including disengaged faculty. Oftentimes, those tend to be the same people. Constant membership turnover, relying on one assessment perspective, limited milestone understanding, and unclear expectations of what the committee's role is and what the process is. Remember, strong CCCs are intentional. Membership should be carefully selected based upon contribution, not by hierarchy. Another frequent question is, how often does ACGME require the meetings to actually occur? The answer is frequently enough to complete milestone reporting. That's the minimum expectation. In practice, programs commonly meet semi-annually, quarterly, or monthly for specific purposes. There's no single correct answer. Meeting frequency should align with your program needs, your learner needs, your committee goals, and your program and institutional culture. For the most part, programs continue to use a semi-annual model. Advantages of semi-annually is it's efficient, it's lower administrative burden and it aligns with your milestone submissions. Challenges of that can be delayed identification of concerns, less timely interventions, and large learner review volumes. Semi-annual reviews can work well if strong assessment systems exist between meetings. However, programs should carefully consider whether issues are being identified early enough. My personal opinion is semi-annual can work extremely well, but I personally, from my experience implementing, I think that when we did it more frequently than that, it worked better than semi-annually. I think 3 to 4 times a year is probably a more appropriate sweet spot. Quarterly meetings offer advantages. They allow earlier identification of your concerns, better developmental coaching, smaller review workloads, and more continuous assessment. Challenges and barriers of that are it's a greater faculty time commitment. That can be a real thing, especially if you come from a program or a specialty that doesn't have protected admin time for your faculty. And then additional administrative burden and preparation. Many programs find quarterly meetings can create a healthier balance between oversight and workload. The more frequent touch points often support stronger learner development. An increasingly common approach is a hybrid model. This combines quarterly check-ins for monitoring progress, coaching discussions, and early intervention, along with semi-annual formal reviews for comprehensive assessment, milestone recommendation, and formal documentation. This model can provide the best of both worlds. It supports continuous learner development while maintaining structured milestone processes. Programs are finding this approach to become more and more highly effective. You want to consider more frequent meetings if you have a larger program, if you have multiple learners that are requiring support, frequent remediation cases, significant milestone concerns, assessment quality challenges, and delays in your feedback delivery. You want to ask yourself, are we identifying concerns early enough in order to support our learner successes? If the answer is no, meeting frequency might need adjusting. This might be the most important message of today's presentation. More meetings does not automatically create a better CCC. Better meetings create a better CCC. Focus on quality preparation, meaningful data review, structured discussions, consistent processes, clear documentation, action planning. A committee that meets quarterly with excellent preparation may outperform a committee that meets monthly without any structure. Quality always matters more than quantity. Across institutions and specialties, high-performing committees share common characteristics. They tend to meet consistently, review meaningful assessment data, use structured decision-making, encourage discussion, document recommendations, focus on learner growth, and partner effectively with their leadership. Strong committees support better learners, stronger programs, as well as improving patient care. As we close, I would encourage you to reflect on your committee even deeper. Ask yourself, does your membership provide adequate perspectives? Are your members actively engaged? Is your meeting frequency meeting your program needs? Are concerns identified early enough? Are we development focused or compliant focused? Finally, what is one improvement that you can implement before your next CCC cycle? Remember that small changes produce meaningful results. Summarizing today's major points, you want to remember that your ACGME requires at least 3 members. You want to select your members based upon assessment value, not their title. Diversity within your perspectives improves your decision quality. Many programs function best with 5 to 9 members. Meeting frequency should support your learner development. Quality discussions matter more than the number of meetings, and effective CCCs improve both learner outcomes as well as your program success. The goal is to have a CCC that meaningfully supports trainee growth. Thank you for spending time with us today. At GME Compass, our mission is to help GME professionals to navigate complexity with confidence, clarity, and practical solutions. If you found this video valuable, subscribe to our channel, share it with a colleague, and leave a comment below. Tell us, how often does your CCC meet? What has worked best for your program? We would love to learn from your experiences and continue to build a stronger GME community together. Until next time, thank you for being a part of GME Compass. Remember, turning GME complexity into clarity and control.